my screen, and I'm going to hand over to Ralph Audehm. So Ralph, as I mentioned, is a GP. He's done heaps of work with the Heart Foundation, work on guidelines, and heaps of stuff on quality improvement in general practice. So I'm sure that you'll really enjoy listening to his short presentation. And thanks very much, Ralph.
Thank you, Joanne. Thank you very much for asking me to give a talk. And, you know, I can always talk on this till the cows come home, but I've got 10 minutes. So I'm going to launch straight into it. So what we're going to be talking about is use of cardiovascular risk calculators, when to use them, when not to use them, and really identify some of the new resources. I hope you've been all tracking the media, but there's been a whole lot of resources released by the Heart Foundation around heart health checks, which have been worked on, and they're very useful for us in primary care. So I'm going to talk about Ralph. So Ralph was a keen golfer. Now, not a true patient, of course, so there's no issues around confidentiality, but he collapsed on his fairway. He was down at the Yarrabend golf course, and, they tried to resuscitate him, but unfortunately at 60 years of age, he was pronounced dead. And, the sad thing was, as a GP, he had just retired to really start enjoying all the things that he did, like his hobbies. Now, this is not an unusual scenario, and this is where we're coming from in terms of the way we look at it. Was this in fact a true sudden event and a sudden death? Or in fact, was this a slow train wreck that we could have predicted and prevented? And, what I'm trying to prove today is that in fact, this is a slow train wreck, and we probably had multiple areas that we could have actually intervened. Now, a year before, he went to his GP. Now, GPs going to GPs, not that great, but he did actually go because his wife insisted that he went. Had a little bit of arthritis from playing too much golf. His blood pressure, 143, but he was given an anti-inflammatory for his knee. Cholesterol, 5.9, HDL, 0.7, non-smoker. Now, what do people think about this? I mean, he's not too bad, is he? Would you think, would people say that, he's pretty average, not particularly high risk? Oh, no one's going to answer? No?
What was the age, sorry, Ralph?
He was 60. 60 years of age. And these are his figures.
And his LDL?
LDL, let's say, was 2.8.
I think if we plugged him into one of the Framlingham calculators, they would tell me to put him on a statin, probably.
Ah, thank you very, very much. And that leads on very much to what we're talking about. So if you look at his individual risk factors, he didn't look that bad. But when you actually plug, this is the CVD check, the Australian Cardiovascular Risk Calculator, and you can see that if we put all those figures in there, he's actually considered to be at a high risk of developing CVD in the next 5 years. And using the current guidelines, he would actually be eligible. Well, we should be thinking about a statin, we should be thinking about an ACE inhibitor, we should be thinking about lifestyle, and so on. So, and maybe we could have prevented poor young Ralph from collapsing on the golf course. And it's this sort of moving away from individual, risk factors, like a 143 is not too bad, 5.9 is not too bad, 0.7 a little bit down, but not too bad. But when you put them all together, he ends up being high risk. And, when you think about the number of events that happen, this is Australian data, and you can see that, really, there's roughly about 4 people having some sort of event per 1,000 people per year. So if you figure that the average GP has about 1,500 patients on the book, you'll be seeing about 6 infarcts, heart attacks per year. And the question becomes, can we actually prevent that from happening? And we'll certainly be talking about the new sort of promotion around heart health and why that can really help us do what we're doing. So before we go any further, there are a group of people who you actually don't need to do a risk calculation on. So these are people, people who have diabetes or over the age of 60, people with microalbuminuria. We know microalbuminuria is an independent predictor of, poor outcomes. And certainly people have chronic kidney disease, much higher rates of heart disease. So these people all deserve to be treated aggressively from the word go. So you don't in fact need to do an absolute cardiovascular risk calculator on them. They do have a serum total cholesterol greater than 7.5 as one of those. And look, I do find that a little bit contentious, because when you're at 7.4, you can have a risk of 1% if you're in your 20s, obviously. And then if you go to 7.5, suddenly you're considered high risk. So, again, we still need to interpret these guidelines according to the person in front of us. Guidelines are only guidelines. They're not telling us what to do left, right, and centre, and to follow, without questioning. Once you've actually worked out where they sit within that risk factor using whatever cardiovascular risk calculator that you use, if you're low risk, we talk about lifestyle. High risk, you give them immediate treatment and you treat them with everything. And then those guys that are in the middle, we would talk about trying lifestyle first. And then, if things remain, maybe tackling the part that's driving the risk the most. And so, we have plenty of time to work with those patients and get it right. So I am going reasonably quick, so we'll have time to talk about later on. We'll have a beautiful case study. But from my point of view, who does need the risk calculator? Of course, it's everybody else. And we know that there are a lot of people at high risk that never get identified and then aren't appropriately managed. So, we're saying, from the group of people, that's about 17%, almost 1 in 5 people at high risk who aren't being treated appropriately. And that's a big swag. We can make a huge impact on, outcomes for people with, at high risk of cardiovascular disease. Now, once you've got those in the middle, or even across all those things, getting people to make changes, we know how easy that is, don't we? We do it every day. Now, so certainly, it can be difficult. It can be, we know that a lot of people who are commenced on a statin will actually stop it within 3 months of given a script. So we do need to think about involving patients in this journey, trying to get them to understand what it is that we're trying to do, so they feel part of that decision making, which will then help them persist with the treatment that we've recommended. Now, motivational interviewing is a fantastic technique. If it's not something that you've done within general practice, have a look at it. It is really fantastic. It works and it's really easy, and it takes a lot of the pressure off you, puts it back onto the patient, and they're the ones that then guide their own therapy, and it works really, really well. It's got a lot of evidence behind it, so do give yourself some time to have a good look at that. Now, I don't know if you've seen, but there's been a lot of information released about heart health checks. I know there's been a little bit of controversy, about why we need a specific item number for it. But, from my point of view, the beauty of this sort of approach, which is in many ways what Future Health Today is about, is we can look at our whole practice, and then we can turn around and say, right, let's screen all our people who are eligible, see where they sit within that risk matrix of heart disease. And using the heart health item numbers allows us to use our practice nurses in a very systematic way. We can track the item numbers so we can know how many have been done. The time that my nurse uses, is used in terms of doing that assessment counts towards the total time. So it really does make it very convenient and very easy for us as, general practices to implement this within our practices. And of course, These have all now been released, and I'd love you to have a look at them. If you have any particular problems, well, there are 2 people who are on the writing group here today, so we can always feed back and, you know, make changes that you think would make it better for you. And then the coronary, this coronary calcium score. Now, the actual position statement from the National Heart Foundation, I don't think has been released yet, but when it comes out, it's actually a good read. So where to use calcium scores, coronary calcium scores. So this is a low dose CT scan of the coronary artery vessels, taking a total sum of the calcium. And then from that, you can actually work out a risk matrix. And it will actually shift people to a high or a lower risk depending on, you know, where you are. There's no point doing it on people who are considered to be automatically high risk, because even if it shows that they're high risk, you're not going to change what you do. People who are really low risk, again, you know, we would normally say the number of people you'd have to screen to make a decision change, you know, is quite large. But it's that in-between group where, you know, you're thinking, I don't think the calculator's actually working out what their true risk is. You may then think about a coronary calcium score. And there's only one other group that I really do. So when you have an isolated cholesterol greater than 7.5 in someone else who is otherwise well, you know, who technically should be on a statin, sometimes I'll do a coronary calcium score, and I'm surprised at how often it's 0. Which is very reassuring that I can say to them, maybe we just hold off on on use of statins. But the guideline will be coming out soon from the National Heart Foundation. There's been a lot of work going into it, so it will be a good read for everyone in general practice. So, sure, did I do it within 10 minutes? Do I get a Guernsey?